All right, let's jump right in. In this explainer, we're doing a high-yield breakdown of laboratory testing and clinical implications for antibacterial agents against Enterobacterales, and we're sticking directly to the latest CLSI guidelines. So here's our game plan. We'll be walking through 6 key sections. We'll start with why Enterobacterales are so clinically important, then get into the nuts and bolts of the 4-tier AST system and resistance mechanisms. From there, we'll cover smart lab reporting and clinical decision-making, and we'll wrap it all up with some must-know pearls for your MD Microbiology exams. Okay, Section 1. Let's talk about the clinical significance of Enterobacterales. This is really the foundational knowledge you need before we can even begin to talk about susceptibility testing. When we talk about this order, we're really focusing on a few major players that you'll see all the time. I'm talking about Escherichia coli, Klebsiella pneumoniae, the Enterobacter cloacae complex, the Citrobacter fruindia complex, Serratia marcescens, and of course, the various Proteus species. And why do we care so much about them? Well, because they're responsible for a huge spectrum of common infections, everything from UTIs and bloodstream infections to nasty intra-abdominal infections and HAP/VAP. Differentiating between those hospital-acquired versus community strains is also a really critical piece of the puzzle. So what's the bottom line here? The absolute core principle for managing any of these infections is AST-guided therapy. The lab result is what should be driving effective treatment for the patient. Period. That brings us to Section 2, the 4-tier AST system. Think of this as the structured, systematic approach we use for testing and reporting, and it's all based on the CLSI M100 document. So what is this system really? It's a hierarchical classification. Its whole purpose is to guide our routine testing, push for better antimicrobial stewardship, and, critically, to make sure we reserve those big-gun, broad-spectrum agents for when we truly need them. Now, let's look at how CLSI organizes this. Tier 1 agents, like cefazolin and cefepime, are your frontline drugs, the ones we test and report routinely. Tier 2 agents, like pip/tazobactam, are secondary. We often report these using a cascade approach. Tier 3 is for our multi-drug-resistant bugs, and this is where you'll find the carbapenems, like meropenem. And finally, Tier 4. These are the heavy hitters, the reserve agents, like ceftazidime avibactam, reserved for salvage therapy. All right, let's move on to Section 3. Now we're getting into the how, the key resistance mechanisms that explain why our antimicrobials sometimes fail. We're dealing with several major strategies these bacteria use. You've got ESBL production, of course. Then there's the tricky business of AmpC beta-lactamases, which can be inducible or depressed. Carbapenemases are a huge one. Think KPC, NDM, and OXA48-like enzymes. And beyond that, you've got other mechanisms like porin mutations that block drug entry, efflux pumps that actively kick drugs out, and complex co-resistance patterns. Okay, I want to pause and really highlight this next point because it is a critical clinical warning: inducible AmpC resistance. This is a notorious cause of unexpected treatment failure. So which organisms should set off alarm bells for this? It's this specific group right here: the Enterobacter cloacae complex, Citrobacter fruindia complex, Serratia marcescens, Morganella morgani, Providentia species, Klebsiella aerogenes, and Hafnia alvae. And don't just take my word for it. CLSISI spells out the risk directly, warning that for these bugs, certain agents may be ineffective due to derepression of inducible AmpC. What that means in practice is that a third-generation cephalosporin might look susceptible on the lab report, but it can, and often does, fail when you use it to treat the patient. This brings us perfectly to Section 4, Strategic Laboratory Reporting. How do we take all this complex AST data and translate it into clear, actionable guidance for clinicians? A cornerstone strategy here is cascade reporting. At its heart, this is an antimicrobial stewardship principle. The idea is simple. We deliberately suppress the results for those broader spectrum secondary drugs if the bug is already susceptible to a narrower primary agent. The process in the lab is very straightforward and logical. First, we test a broad panel of drugs. Second, we look at the results for the Tier 1 agents. Third, if the organism is susceptible to a good Tier 1 option, that's all we report. It's only if it's resistant to those that we selectively release the results for Tier 2 or Tier 3 agents. Another key strategy is knowing the difference between surrogate and direct testing. With surrogate testing, we use one drug's result to predict how another will work. A classic example is using cefazolin to predict susceptibility for oral cephalosporins. Direct testing, on the other hand, is just what it sounds like. We test each drug individually to get a precise minimum inhibitory concentration, or MIC. Now, for urine isolates, there are some non-negotiable reporting rules you just have to know. The cefazolin result predicts oral cephalosporin efficacy, but only for uncomplicated UTIs. Nitrofurantoin results. They're only valid for cystitis, not for more serious infections like pyelonephritis. And phosphomycin susceptibility should only be reported for E. coli causing an uncomplicated UTI.
Okay, we've got the lab data. Now what? Section 5 is all about pulling it all together into a solid clinical decision framework to get the best outcomes for our patients.
And it really boils down to a few core principles. First, always select the narrowest effective agent possible. Second, don't just look at S or R, consider the MIC value in the context of the clinical breakpoints. Third, keep an eye out for evolving resistance during therapy. And finally, none of this works without clear, direct communication between the lab and the clinical team. All right, let's wrap this up with the most important part for many of you. Section 6, the MD Microbiology exam pearls. These are the high-yield points you need for your theory, practical, and viva exams.
For your viva, you should absolutely be ready to define cascade reporting and explain its role in stewardship. Be prepared to list those genera with inducible AmpC and clearly explain the clinical risk of using a drug like ceftriaxone against them. Also, be ready to explain the reporting restrictions for phosphomycin and the role of cefazolin as a surrogate marker. You'll also want to have these key drug-organism associations locked down. Remember, cefapime is your preferred Tier 1 agent for those organisms with an inducible AmpC. Orthoponine resistance is a major red flag. It's a key marker for potential carbapenemase production. And astranim might function as a Tier 3 agent, especially if metallo-beta-lactamases are a big problem in your area. So, for a rapid-fire revision, here are the absolute key takeaways. 1. Enterobacterales are major pathogens, and AST-guided therapy is essential. 2. The 4-tier system is our framework for stewardship. 3. Inducible AmpC is a critical warning. Avoid third-gen cephalosporins in those key genera. 4. Cascade reporting and surrogate testing are key lab strategies. And 5. Those urine-specific rules for cefazolin, nitrofurantoin, and phosphomycin, they are mandatory.